Welcome back. My name is Dr. Andrew Smith. We're here talking about how we're building this community around social connection and belonging, and how important it is that we start making strides in that direction, both for our young people, kids now, teenagers, college age, um, as well as for those of us in middle age or beyond, that we are living in a cultural time and moment where our sense of disconnection and polarization are absolute facts at a population level. So today I want to talk about why we haven't done a better job from medical and scientific standpoints producing interventions that we could scale for many people to have access to. Evidence-based treatments are treatments that we study and build support and evidence for, so that we know that when we deliver those treatments to people, that they'll get some benefit from that, or they're likely to get some benefit from that and not harms. And we've developed evidence-based treatments for lots of different types of conditions, from physical medicine diseases to mental health conditions like depression and PTSD and anxiety. But what we've known for a really, really long time, more than 50 years, whether it's been studied from sociology or neuroscience or psychology or public health perspectives, is that social connection cuts across all types of disease. It is the most replicated mechanism or predictor of whether or not somebody's going to, for example, respond to trauma in ways that allows them to recover and bounce back, or respond after a cancer diagnosis and experience good outcomes in those types of difficult situations. How people bounce back from cardiovascular events such as heart attacks. Social support sits at the very core of how we function as human beings, and it's replicated over and over and over again as a really important, strong predictor of how healthy we are, almost regardless of the context that it's being studied in. So since we know that much about it, you'd think that we would have interventions that approached this from all kinds of different angles and directions, and were widely available evidence-based treatments focused on social connection. But the difficult and unfortunate situation around that is that we haven't produced those kinds of interventions in ways that are tested and that have evidence base behind them, and that are scalable, meaning a lot of people can have access to them because they are they're feasible and simple enough for lots of us to be able to benefit from them, and versatile enough. So let's talk about a couple of reasons why that's been the case, and why I have gone about the process over the last several years of developing this intervention approach that we think is scalable, that can help a lot of people, that we call Rewire, which stands for Re-engaging Worthy Interpersonal Relationships, which is an evidence-based intervention that we are using to try to scale to as many people as we can, because we think this problem is so important. So here's reason one why social connection hasn't been targeted in evidence-based and rigorous ways in the science. It's hard to make money on these kinds of interventions in our current medical model. So the medical model is built on billing insurance to be able to treat, diagnose, and treat conditions that insurance companies allow hospitals and providers and clinicians to bill for. So the research agenda in U.S. healthcare, and including mental health care and physical health care, both of those dimensions, has really been driven by a medicalization and a diagnosis-heavy approach. So for example, 96% of veterans enter mental health treatment, and their number one reason for doing that, 96% of veterans report that something is messed up or dysfunctional about their relationships, and that's why they're seeking mental health care. Because diagnosing and billing relationship dysfunction isn't really a feasible process in our medical world, and in the agenda in a medical model approach that's built on profit models. That veteran is rerouted to a PTSD clinic or a depression clinic or a substance abuse clinic because those are medicalized diagnoses, much more so than loneliness or marital dysfunction would be. So the federal funding mechanisms that come with bench science and research oftentimes are guided and driven, even though there's big talk about preventative care, which social functioning falls into, building a better preventative care system. The majority of this work falls into a medicalized, disease-based approach. Let's talk about reason number two. Reason number two is that because social connection crosses all of these different disciplines and conditions as what we call a transdiagnostic process or variable or mechanism, because it's an important variable in vascular medicine, and it's an important variable in psychiatry, and it's an important variable in public health settings. There's no natural owner of this, and there's no governing body through which this would really coalesce into a real rigorous science that allowed us to move an intervention forward. Additionally, all of those sociologic, psychological, academic medicine, all of those groups of folks are also pursuing funding based on this medicalization system, wherein diagnosis and medical treatment, disease-focused treatment, are the way that that's basically the funding that they're pursuing. So there is no governing body or owner of this problem called loneliness or social disconnection, sense of not belonging. So even though the U.S. Surgeon General has said this is my number one priority, this is a crisis level, this problem of social connection, the science on how to offer some kind of treatment to our culture and our community that would do something about this in a way that an evidence base already exists on is really not there. Which is where we came around and started to develop Rewire out of my scientific academic work. And we'll unpack and get into that as I go through more posts. I want to finish with a case example that I think makes this all make a lot of sense. Why we haven't developed interventions and how the disease/medical model kind of drives the agenda for why it's not profitable from a medical billing system standpoint, and therefore not a priority, despite lip service about social support being really important. Okay, so let's call this patient Dave. So Dave comes in to my clinic, and one of the first questions I'll ask is, Dave, what's got you wanting to come and see somebody like me? What's your presenting problem? And Dave responds by saying that he's lonely, that he's struggling with some mood and anxiety symptoms, low motivation and fear of difficulty relaxing and difficulty sleeping, and that he's really suffering from these things, and that he would like help with these. And so I give him a measurement of these mood symptoms and anxiety symptoms, and lo and behold, he does have mild to moderate depression and anxiety. And we know that there are a ton of people like Dave in our culture who are struggling with mild to moderate symptoms of depression and anxiety. Um, so Dave says his number one reason for coming in is because his relationships are really suffering, and that he would like help with that, and that he thinks his mental health is responsible for that. So in a medical model world, which is largely the way that Dave is going to be responded to right now, a psychologist or psychiatrist will say, okay, Dave, you're feeling lonely. You've got some mood and anxiety symptoms. Let's go ahead and and your primary goal is relationship development and feeling better. So let's go ahead and prescribe you an SSRI to deal with the disease part of this. And then when your mood and anxiety symptoms lift, then you'll feel a lot better and you'll be able to get out and relate to other people better. The problem is this may not, it may not work, and we don't have a great science on understanding whether or not when somebody takes a medication, they feel better enough and then their relationships improve. That requires investment in longitudinal research that happens across time so that we could follow Dave across a very long period of time to see if that lift in his mood, that minor lift in his mood that comes from medication, produces the energy required to go ahead and improve his relationships. There's a problem. Dave is struggling to know how to feel more connected, and a medication isn't really going to help him. Per se. That's a big assumption, at the very least. So if you, there's another way that you can approach Dave's case, which is, okay, Dave, you're really motivated to feel better, and you're motivated by wanting to develop deeper and better connections. What if we focus on Dave's connections, Dave's social connectedness, as our first step? What if we helped Dave to build a network or deeper relationships within his existing relationships so that he felt a deeper sense of belonging? Would then his mood and anxiety symptoms lift? Actually, the literature is much more clear on that idea. So that when he feels more social support, his mood and anxiety symptoms go down. See, we're cutting this off. We're cutting this opportunity to help Dave focus on his relationships as a means of improving his mental health. That this is actually maybe, in part at least, a problem of social connectedness, more than it is a psychiatric disease. Mild to moderate depression and anxiety symptoms, a huge portion of Americans are taking medications for those things. And for some people, that's probably really helpful. But for a huge, larger portion, we've been selling them a medical model that says, treat your disease with this quick-hitting medication, and that will make all the things get better. The problem is we're not seeing it in the numbers. The rates of mental health distress aren't going down, they're going up. And so what if we started focusing people like Dave on social connection, and then after some time, working really hard on that process with a dialed, focused treatment for that, we could reevaluate and reassess whether or not Dave still needs that medication 5-6 weeks later. So that's the kind of philosophy that we're building around, is that we've gone for the low-hanging fruit of disease diagnosis and treatment, and it's only helpful for some people, and we've over-identified our population with disease. How many kids and teenagers are using and identifying with the language of mental illness right now? If you spend any time in those environments, we have really taught our population how to identify with mental health or mental illness diseases. There's another way. There's a way to be all in together on this idea that we're all struggling to feel a sense of belonging and connection, and that if we worked a lot harder at those things, that some of the noise, some of the some of the severity of these things that we're calling mental health or mental illnesses will start to improve. So that's really what we're putting our nickel on. We will do more of this, but I hope you'll stick with me and learn more about what we're building here at Rewire, and we'll go from there.